Thank you, Chris. Thank you, Richard, and of course, guest editors and co-workers on this Lancet series, and good afternoon to the audience. It's my pleasure to present to you the second paper entitled Combination HIV Prevention for Female Sex Workers, What is the Evidence? And I just want to acknowledge the stunning lineup of co-authors that have helped me to produce this and thank them for all their hard work. So I do want to just acknowledge my own past president, who we sadly lost last year, and some of you may know lost his oldest son to this infection. He asked us to have bold and courageous initiatives to prevent new infections and recognize that it would take both boldness and courage, but also in that process, never to deny people their human rights or their very humanity. So when we look back over the last 30 years, it's striking that sex workers have contributed to the HIV research agenda in many ways, in terms of understanding immunopathogenesis, in the early microbicide trials, in understanding the role of community participation with the Thai 100% condom uptake program, well known to this audience, and more recently, the good participatory guidelines that emanated from the stoppage of the early pre-exposure prophylaxis studies in a number of parts around the world. But more recently, we in fact have not seen sex workers involved in some of the more novel HIV prevention work. And so as we did our comprehensive review for paper 2, we noted that information specifically related to HIV prevention in female sex workers, particularly in regard to the new biomedical technologies, was sparse. And so we had to broaden our search in order to be sure that we would include potential HIV prevention interventions that may be available to this important population. To do the work, we considered 2 already published frameworks and combined them. So we recognize that female sex workers operate within the world in a number of different levels and have a number of risk levels, from the individual through networks, communities. They exist within public policies and obviously within environments and settings. And to consider the idea, which has really come about since 2010 or so, really with the last Lancet series on prevention, that of tailored combination prevention. We wanted to think of this in the light of a combination of structural with social justice and human rights, behavioral components, and of course the biomedical art and non-art components as well. So what exactly is tailored combination prevention? What have we come to understand? Well, within the setting of sex work, I think we have to say it's effective prevention really requires knowledge of the sex work setting and the environment. I think what you will learn this afternoon is the extraordinary diversity of the population and the various settings in which sex work can occur. We need to recognize that sex work autonomy and freedom to choose, that there should be full involvement of peers in design and implementation of our programs, that it employs a layered combination approach, and it includes, after implementation, careful monitoring and evaluation to measure the impact and also to ensure that there are no unanticipated harms. So let me tell you about the menu that we discovered by going through the literature. Well, first of all, there are established interventions. First of all, the well-known condoms. And it's striking that this population, more than perhaps any other population, has taken up condoms. But as we think about it, we need to remember this is an absolutely key ingredient in any menu. Male and female condoms, condom-compatible lubricant, and always paying attention to access and cost. Then, of course, voluntary testing and linkage to services with, up until now, poor coverage in female sex workers, but seemingly, again, coming through in the literature, improving around the world. We always have to recognize that in addition to the usual barriers to VCT and linkage, sex workers face extraordinary additional barriers that are particular to themselves around disclosure and other fear issues. Very important that we provide sex worker-friendly health services, including sexual and reproductive health services. And this should, of course, include STI treatment, comprehensive STI treatment, and contraception. Here's a voice from a female sex worker in Zimbabwe who said, "The nurse said to me, 'How can you, a sex worker, even have high blood pressure? It's high because of too much sex. You are wasting our drugs instead of us giving them to those who have proper high blood pressure, caused by women like you when you take and infect their husbands and them eventually.'" I'm glad to say that in response to this kind of feedback, the Zimbabwe National AIDS Council has actually set up a fantastic program called Sister with a Voice. It's been on the go since 2009 and now exists in 36 districts in Zim. And the best news is that under the leadership of Francis Cohen, the Sapphire Project is now building on that wonderful program and will be looking at combination prevention within that setting. So continuing with established interventions, of course, economic strengthening and supplemental income comes into the literature. And more recently, there are people beginning to explore conditional cash transfers and other incentivized programs. Behavior change through peer education and community-based counseling also has some evidence. And then, of course, for where key populations transect, particularly female sex workers who also use and inject drugs, harm reduction is clearly very important as another ingredient. Gender-based and police violence, you've already heard a lot from Steph, is a real and significant barrier to good prevention. Just from recently from Sweat in my own country, again, sex workers have named that police are the perpetrators of violence in more than 50% of the time. Here you see the late General Maswangani, who actually epitomizes a policeman who recognizes that policemen are there to provide rights and protection services. And you'll read an excellent commentary from a policeman in this series from Amsterdam who had a similar way of thinking. Sadly, the general was murdered last year in my country. Community empowerment, another very important concept, the promotion of social cohesion and capital, inclusion, and of course leadership skills, all very important, and there's evidence there too. And then finally, advocacy and community mobilization with policy programs and services. So then we think about the new interventions where I have already mentioned that really the data is light within sex workers, and that's because more recently we have not actually meaningfully included sex workers within these the most recent clinical trials. But we know that post-exposure prophylaxis services exist, and in this setting would be useful for sexual assault and unintended exposures. Then, of course, pre-exposure prophylaxis with antiretrovirals, and this includes both oral PrEP as well as topical or microbicides. And then bearing in mind, of course, that sex worker-friendly healthcare and antiretroviral treatment is a human rights requirement and a very important consideration, including the provision of mother-to-child prevention. So let me again draw your attention to the pre-exposure prophylaxis trials that have already been conducted. And many of you will have seen this kind of data, but what I wanted to show you was what we tried to do was pull out from each of the clinical trials how much have actually involved sex workers. And what you will see here is that in none of the clinical trials were sex workers specifically enrolled. In some of the clinical trials, at least a question around transactional sex or sex was asked. And again, you see low numbers of these individuals actually admitting to this kind of sex work. Important, though, also to recognize that except for 2 clinical trials in which the use of the product was too low to actually show efficacy, you can see in those in whom adherence was good, we have point efficacy amounts from 54% right up to 92%. And so it's for this reason that we really wanted to put biomedical interventions on the table, because I think that there is no doubt now that these interventions can work if indeed they are used. However, we are aware that having extrapolated into this population, it's also important that we recognize that there may be particular factors associated with sex work that could have an impact on PrEP effectiveness. And we've put together, and it's not really for this afternoon, but I ask you to look at the series, read the paper, and see some of our ideas of what might need to be examined and may play out as we think about using these biomedical technologies in more populations than to date. There is no doubt also that secondary prevention is important, and I've already mentioned access to antiretrovirals for sex worker health is clearly an important ingredient, but regular voluntary counselling and testing with commencement of ART at earlier stages of infections, meaning higher CD4 counts, may also have a secondary prevention impact in terms of clients and intimate partners. You are all familiar with the HPTN 052 study, which showed significant reduction in HIV transmission between linked discordant couples in whom one of the partners was suppressed on ART. So we went on also then to model the impact of these biomedical technologies as part of combination prevention packages within the sex worker community in South Africa. Now, as you know, South Africa is a generalized epidemic largely driven by heterosexual sex. And I think it's important to, again, as this conference is doing, recognize that within these generalized epidemics, there are key populations and specific populations who often, therefore, have higher prevalence than the general population and need specific tailored combination preventions. Our modeling showed that in 1990, the contribution or the burden of disease that was attributable to sex workers was about 11% in South Africa. In 2006, it was probably more like 6%, and this is as the generalized epidemic really took off. But we looked at the impact of applying topical PrEP, oral PrEP, as well as an early treatment intervention, and you can see what each of those individually would do and then what the combination would do in terms of further reduction of new infections between the years 2015 to 2025. It is again important to note that because of the established prevention interventions, namely in this case mostly condom uptake, we had already estimated a reduction in infections in our sex worker population of up to 70%. So we're seeing an up to 40% increase due to these biomedical technologies, but that is extraordinarily dependent on our assumptions around uptake and efficacy. And so you can see quite wide confidence intervals depending on how much is actually used by the population and indeed how efficacious or effective these interventions will be in this population. We need to understand better what some of these figures will be and document this as we think about rolling it out. So as I wrap up, what actually will our menu look like? Well, as we go through the risk levels, we would suggest that at risk level 5, we really do, each of us need to know our sex worker epidemic, what the burden of disease is, and also then know what the response is that we need to do. At level 4, there clearly is a requirement for policy reform and decriminalization. You're going to hear that word a lot this afternoon. Safer working conditions, less police brutality, and of course, sex worker empowerment. At level 3, community-based and led services, advocacy and mobilization, less stigma and discrimination, and peer-led behavior change. At 2, social sexual networks are very important, and here indeed drug injection may be very important, STI control, condom promotion, harm reduction, and reduction in all forms of gender-based violence. And finally, at the individual level, This may be the place for certainly behavioral and biomedical interventions. Of course, condom usage, regular sexual and reproductive health care that is sex worker friendly and non-prejudicial, voluntary counseling and testing, PrEP, and always bearing in mind that this field is evolving with the future of injectables, depot-vaginal rings coming, and rectal microbicides. And then early treatment, both for the health of the sex worker herself, but also as a secondary prevention of clients. So to conclude, effective HIV prevention interventions for female sex workers have not been taken to scale in most parts of the world. Stigma and criminalization form barriers to existing effective interventions. Female sex worker prevention packages must include sex workers in the design and their implementation, and newer biomedical technologies should be additive to and not replacements for established interventions. PrEP has been shown to be effective in men and women, although sparse evidence exists in sex workers. Art is critical for sex workers living with HIV, and earlier art in positive female sex workers will benefit clients directly and sex workers indirectly. Tailored combination prevention interventions for female sex workers are likely to have the greatest benefit. And the final word, if we can help and see that sex workers organize where the police do not harass and where sex workers are free to avail themselves of quality, non-prejudicial, and sex-friendly HIV services, sex workers will have a lower rate of STIs, more economic power, and a greater ability to educate their children. I just, again, also thank all of those people who made this possible.